Finally. Finally, we've gone live. It's Madaka. Jesus Christ. Now use the same address now. For that.
Say I did the same payment. How much?
Okay.
How much?
Man, send it for you.
For me,
How is he angry? My plan don't get wahala. Really, unless I don't give a virus.
we share with some.
No, I know the share the virus. See my hard drive, see my plan, I know the share with you. That's why I have this smart. That's why yeah now.
Hi, Ikenna, can you move Byron in here? Thank you. Move Byron and Dr. Lakunde. Thank you. Ikenna, can you move Byron and Dr. Lakunde? Okay, can you move Byron in, please?
Hello, man.
How are you?
I'm doing well. How are you doing?
Good. Thank you so much.
Of course, thank you. Tanya.
No problem.
Hi, Byron. Hi, Emmy. Hi, Prof.
Yeah.
How are you doing, Yemi?
I'm very good, Prof. I was greeting you there. How you doing? Hope you're enjoying yourself.
I don't know. It's been a work, but it's been good.
Wait, I'm sure you're eating goat meat pepper soup. I'm from where?
Yes, I can't complain. Today is fresh banana and peanut and angara for lunch.
You didn't tell him about the boiled corn and the ube.
Yeah, that is for dinner. You don't want me to make him hungry, do you?
Yemi, you're making Yemi very, very, very envious of you.
Don't worry, I'll send you pictures, Yemi. I'll make sure when I put the plate before I eat, I'll send you the pictures.
Well, okay.
That's torture.
So we give a few minutes and then we get started. We try to start on time. So I welcome everyone to our third day of the Nisa Research Week. And I am excited and very grateful to invite someone that we have known for a long, long time. So Baron Powell, Dr. Powell have been, I think he was our first or second speaker at Nisa the first time we started. And he was in Nigeria, in Abuja, as our guest speaker at the time. And we are grateful and we are looking forward and hoping that he will be back again. If not this year, definitely for our 10th year. So we're hoping one of them that will work. But this is Baron Powell is an associate professor at the Brown School and the School of Medicine at Washington University in St. Louis. He is the co-director of the Brown School Center for Mental Health Services Research and the co-director of the Institute of Public Health Center for Dissemination and Implementation. He also serves as the co-editor-in-chief of Implementation Research and Practice, and he holds an adjunct appointments at UNC, University of North Carolina, Chapel Hill, and University of South Wales. So today, Dr. Byron will be joined by Dr. Olakunde. Babayemi Olakunde is an assistant professor at the University of North Texas, and he also serves as the associate director for the Sunrise Oncology Applied Research Center at the Irvine Research Institute. He formerly was an assistant director at the National Agency for the Control of AIDS, where he played a pivotal role in the national HIV response and managing government and partner-funded HIV projects. His area of research and interests include health services research, implementation research, and epidemiology. Like we have done for the past 3 days, we are going to allow Baron to go for the first and present on the exciting ERIC strategies. And then Dr. Olakunde is going to talk about how the team in Nigeria have used the ERIC strategy in carrying out their research. So once again, welcome, Dr. Powell, and you have the floor. Thank you.
Thank you so much, and good afternoon, good evening, folks. Thank you for the opportunity to be here. I'm excited and do hope to return to Nigeria at some point soon. So let me just share here and I'll get started. Okay, hopefully that's working okay on your end. Just by way of overview, and if we don't get through all of this, that's okay. I hope that we'll have plenty of time for good discussion and dialogue today. But I hope to share a bit about our work to identify and classify implementation strategies. And then I'm going to spend perhaps more of the time talking about designing and tailoring implementation strategies, the importance of specifying and testing mechanisms of change, and the importance of carefully tracking and reporting implementation strategies in research studies and other implementation-related evaluations. And again, hopefully we'll have plenty of time for discussion thereafter. So I'm going to start just by laying some groundwork and making sure we're on the same page with terminology. This, of course, shifts across the field and in the literature, but we talk about implementation strategies often as methods or techniques used to enhance the adoption, implementation, sustainment, and scale up of a program or practice. And in our work, we've talked about different types of implementation strategies. So sometimes we talk about discrete implementation strategies that arguably involve a single action or process. So things like clinical reminders, audit and feedback, where we might measure performance of clinicians or others and feed that back to them in comparison to their peers often. Or clinical supervision in an area like mental health or other areas of clinical practice that might be considered discrete or single component strategies. Now, admittedly, these are complex interventions in and of themselves. And so discrete might be a bit of a misnomer. But the idea here is that oftentimes in implementation, we're also dealing with more complex implementation strategies that involve multiple discrete components. And so We might refer to those as multifaceted or even multi-level implementation strategies. You may see the term implementation interventions or any other, probably a variety of other terms to describe what's essentially a package of implementation strategies that hopefully are combined in a way such that they are working together synergistically to address key determinants of change and hopefully in a way that will allow us to achieve our implementation and clinical and public health outcomes of interest. So just to set the stage here, we originally went to the literature. This was over a decade ago now, to look at what are effective implementation strategies. We've identified a number of evidence-based practices and evidence-based practice processes. What are some implementation strategies that can help us to move effective practices into routine care? And when we went to the literature, what we found was this sort of Tower of Babel problem, that people were using the same term to talk about totally different strategies. People were using different terms to talk about what's essentially the same strategy, and that there was a lot of inconsistency across the literature about how strategies were named and defined. And so in conducting a review of the literature, we published this first paper in 2012 in Medical Care Research and Review, where we simply wanted to name and define these implementation strategies. And so we developed a compilation of 68 discrete strategies, named them and defined them, and we categorized them into 6 broad categories. And we thought that was a useful start, but was really just based on a review of the literature. And we thought it'd be nice to advance that work further. Fortunately, we were approached by Joanne Kirchner, Tom Waltz, and others at the Department of Veterans Affairs here in the U.S., who were looking to develop specific recommendations for implementation strategies within the VA. And we had this opportunity to refine our original compilations through this project called the Expert Recommendations for Implementing Change project. And so the first step of that was to conduct a Delphi process, a 3-round Delphi process where we essentially vetted these definitions and terms by experts in implementation science and practice. We then also had them complete a concept mapping exercise to essentially develop conceptually distinct categories of implementation strategies. We also had them rate feasibility and importance for these strategies. And so the middle paper here represents the ERIC compilation, and oftentimes I point people to the additional file 6 of that paper for perhaps the most comprehensive set of definitions on these implementation strategies. The paper on your right represents the 9 distinct categories of implementation strategies, which I show here on this slide. And so I won't belabor this, and certainly Dr. Alokunde is going to share some examples of this from his work. But we essentially developed this compilation of 73 discrete strategies in these 9 categories. Again, you can see that in an additional file 6 of that paper if you'd like to read more about that. The main purpose for this work was really, again, to help to develop a common language for the field, but also to identify building blocks of what could be used for multifaceted, multi-level implementation strategies, whether that's for research or practice. We hope that sort of, although not maybe solving the Tower of Babel problem, that we promoted a common language and improved reporting in the field by coming up with some terms and definitions that could be used consistently across research. But I'll note here that there's plenty of room for critique, dialogue, and ongoing refinement of this work. And so excited to see people advance this in different ways, and we're certainly working to do that in some of our work as well. We've been pleased to see this picked up at least through the NIH and the Department of Veterans Affairs and other institutes in the US and some internationally as well. But again, we've been particularly glad to see people challenging this work and really moving it ahead. One of the key teams that has done this is Sherry Rogal, Very Yakovchenko, Matt Chinman, and their team at University of Pittsburgh here in the US. one of the things that they've done is use this ERIC compilation as a method of surveying participants and implementers to see what types of implementation strategies are they using, and how effective are those strategies within large-scale national implementation efforts within the VA. So I know this is a lot of papers here, but wanted you to have these as resources. The top 3 papers here on the top row here represent their use of a survey instrument longitudinally within a national implementation effort, where they can show different strategies and their effectiveness with respect to improving treatment starts for hepatitis C. The paper with the red box around it actually represents their work to refine this survey over time. And so one of the things that they've recognized is some of these terms and definitions are confusing. They might be sort of double-barreled as they or even triple-barreled as they go to refine the survey. And so they've really worked and are continuing to work to refine that survey so that it better reflects actual implementation efforts and the strategies used. I also just wanted to quickly point out, I think one of the neat things that they've done is use these methods called configurational comparative methods. And you may have come across these methods. These are really based upon the notion of equifinality, that there's more than one way to be successful in implementation. And so these methods allow you to identify strategies that are both necessary and sufficient to achieve your outcomes of interest. And so both the papers on the bottom right, I think, are quite interesting examples of that, if you have time to check them out and are interested in applying those methods. When we developed the ERIC compilation, we intended this to be relatively generic and sort of applicable to a wide array of settings within healthcare and social services. But we've also seen people usefully adapt this compilation for specific settings. So for instance, Clay Cook and colleagues adapted this for school mental health. Andrea Graham and colleagues have adapted this for digital mental health interventions in healthcare settings, and really taken a look specifically at the types of barriers that these strategies can address within those settings. Alex Dopp and colleagues have conducted a scoping review wherein they identified 23 different financing strategies in behavioral health. So I believe our original compilation probably has 8 to 10 financing strategies, and this really expanded that work. And so again, really just trying to illustrate that there's room for critique and expansion of this in a variety of directions. We've also been asking questions such as, how do the ERIC strategies, as we've defined them, apply to things like sustainment or de-implementation when we want to get people to stop using things that are either no longer effective or maybe even harmful. The paper on the left represents an effort to do just that, is to sort of ask, how are these strategies relevant to sustainment? Some of these strategies were refined a bit, or their definitions were refined to better address sustainment, and perhaps a relatively few number of strategies were added to this compilation to reflect sustainment efforts. I think Dr. Nathan's paper is also really helpful in specifying the specific stages at which, or phases at which, the implementation strategies might be considered and applied. Maybe not the final word on that, but of course, I think a helpful tool on that front. And again, for de-implementation, we've started to apply the ERIC compilation. This is a paper by Sarah Ingvarson and colleagues who applied the ERIC compilation to a scoping review of de-implementation strategies and found that those terms and definitions could be useful in categorizing de-implementation strategies within that work. I think, quite relevant to this crowd, one of the critiques of the ERIC compilation originally that I didn't mention is that this was a really North America-centric and really a US-centric endeavor. Of course, we drew upon the broader literature, and so did not restrict our literature search to work being conducted in North America. but a large, but really the majority, or actually all of the participants in our original Delphi study were from North America, largely from the US and just a few from Canada. And so the question of how these strategies apply internationally has been asked. Recently, Kate Lavero led a systematic review of implementation strategies in low and middle income countries. And particularly, we're looking at studies that use the ERIC compilation and found that there are an increasing number of studies using that compilation, and that those seem to be applicable. But there are ongoing questions about, should this list be expanded or refined for these different settings? Elvin Gang and colleagues have led a living meta-analysis of implementation science in low and middle income countries in the area of HIV, and have used the ERIC compilation as along with something called the effective practice and organization of care group taxonomy to code the implementation strategies being used in those settings. And one of the things that they found was that there were a lot of strategies that focused on sort of patient, patient-focused implementation strategies that were not accurately captured by either the ERIC compilation or the effective practice and organization of care compilation. So again, suggests potential areas for refinement. We also have work underway to translate ERIC into other languages. So it's already been translated into German. The Spanish translation is now in Revise and Resubmit at Implementation Science Communications, and it's being translated into Japanese. Hopefully, we'll see an increasing number of languages to increase the utility of this work internationally. There's certainly a number of other tools that you could think about to better characterize the implementation strategies that you're using, to use consistent language, and to really, help the conceptual alignment of your implementation strategies with the context that you're working in. One set of tools is the behavior change methods that is associated with the implementation mapping or intervention mapping work. If you're familiar with that, I'll have a couple of slides on this later on. But the link to the full compilation is here in the slides, which you'll also have access to. And I think this is a really nice set of behavior change methods that represents different socioecological levels. So it can be really helpful in thinking about potential techniques that you might use to operationalize the implementation strategies that you're using. You also might be familiar with the behavior change technique taxonomy by Susan Mickey and colleagues. We've done some work to see how are these behavior change techniques complementary to the strategies as we've defined them in the ERIC compilation. Sheena McHugh from the University College Cork in Ireland has published this paper where we examine the complementarity. And one of the things that we found is that the ERIC compilation strategies are defined quite broadly. So for some of them, it's actually quite helpful to think about what are the actual behavior change techniques that are embedded within those strategies or could be used to sort of tailor or operationalize those strategies for a given setting. In other cases, the ERIC compilation strategies were actually more detailed than the behavior change techniques. And so there was sort of a really nice complementarity there that's highlighted in that paper. And finally, I'm not sort of deep into this work yet, but if you haven't been following the Human Behavior Change project, they've done an enormous amount of work to advance the behavior change technique taxonomy, and they're now have sort of developed it into an ontology where they're looking at, in addition to behavior change techniques, they're also looking at mechanisms of action and behavior change interventions. So I think many of these papers are also relevant to implementation science, even though they're really couched in this sort of health behavior change space. They're quite relevant to implementation science and implementation strategies. So would urge you to take a look there. I won't share a ton about the evidence for implementation strategies, but just wanted to suggest that, as many of you are aware, that the evidence for the effectiveness of implementation strategies is growing. Mostly the effect sizes are small to moderate, but we have a growing number of trials that demonstrate the effects of implementation strategies for things like, printed educational materials, educational meetings, opinion leaders, audit and feedback, and the like. Many of these reviews have been conducted over the years by the Cochrane Effective Practice and Organization of Care Group, amongst others. And many of these reviews are being updated. And so there's more recent evidence coming out that in some cases doubles the number of trials in the previous reviews or even more. And so it's really nice to see the development of evidence in this space. We've also seen sort of critiques about the usefulness of systematic reviews and meta-analyses of implementation strategies, and suggesting that we need sort of different types of primary studies potentially, and different synthesis methods to really advance our understanding of how and why these implementation strategies work. This is a really recent paper by Annette Boas and colleagues, who suggested that future research should really shift away from merely examining what works to really focusing on what works where and what works for whom. They also emphasized the exploration of complex and the situated nature of evidence. So really, again, more contextually driven inquiry. And they also urge us to explore the complex processes involving a range of actors with differing capacities working in diverse organizational cultures. And so I think a really helpful paper that provides an overview of, in this case, 86 systematic reviews of implementation strategies. So again, no shortage of evidence for implementation strategies. In line with those recommendations, we've also seen methods such as realist reviews that are really striving to focus more on how and why implementation strategies work. I know that this slide is ridiculously complicated, and so maybe you can't take this in here. Again, you'll have these slides and references. But this is a paper by Singh and colleagues that looked at pay for performance in LMICs. And one of the really nice things that they did here is they presented an initial program theory for how pay for performance works. And then they conducted the review, and they showed where their initial theorizing was consistent with the literature, but they also showed where they revised their theory based on the literature review. And all of this is captured in a causal loop diagram. This is a system science method that really shows the balancing and reinforcing feedback loops that help maintain these systems, and also really helpfully, I think, identify potential leverage points for intervention. So I think increasingly we're asking that evaluations of implementation strategies embrace complexity and really try to articulate how and why implementation strategies work and how we can actually refine them over time to enhance their effectiveness. So as we move forward, having identified a set of implementation strategies, having established that we have a growing evidence base to support their use, we're also faced with this notion that oftentimes in implementation science and practice, there's little association between the type of problems that we're facing and the types of approaches that we're taking to address them. And in particular, organizational and system-related problems tend to be ignored in favor of individual educational and psychological approaches. This is something that Michel Vensing and Richard Grohl have noted. It's been noted in a number of papers in the field, where we just have this mismatch between what we're doing and the types of problems that we're facing. And so we've suggested a number of potential ways of sort of improving the impact of implementation strategies in public health and healthcare services, as well as social services. And I'm just going to focus on the first three here today. The first is we're going to talk a bit more about how we can enhance methods for designing and tailoring implementation strategies. Second is we're going to talk a bit more about how we can better specify and test mechanisms of change. And then finally, how can we improve the tracking and reporting of implementation strategies such that we can replicate effective approaches, and we can tweak or go back to the drawing board when we are ineffective in our implementation efforts. Of course, I'm not going to spend much time on conducting more effectiveness research and trials of implementation strategies. I'm also not going to spend much time on economic evaluations, but both are really important directions moving forward. And I'll just note that I'm not monitoring the chat, but please do interrupt if there are major questions as we go. Otherwise, we will certainly have time for discussion. So there are a number of different sort of systematic ways of developing and tailoring implementation strategies and methods that are emerging in this space. But I think many of these, including intervention mapping or implementation mapping, share these sort of common steps. And so this is adapted from a paper that French and colleagues wrote in 2012 in Implementation Science, wherein they suggest 4 main steps for developing theory-informed implementation strategies. And I'll note here that I think, considering equity at each of these steps is really critical, which maybe, starts in part by considering who needs to be at the table as we design and tailor implementation strategies. And so the first step of this process is really identifying who needs to do what differently in order for implementation to be improved. So thinking about the multiple levels of behavior change that need to occur, who needs to change their behavior, and really specifying those individuals. Oftentimes in implementation efforts, as you all probably know, we overlook obvious groups that might be either affected by implementation or might be directly contributing to implementation efforts or need to be. The second step here is using informal and formal theory and frameworks to identify barriers and enablers that need to be resolved, and to articulate a pathway of change for targeted behavior change to occur. And I'll just note here, I think this is something that's already been focused on this week or will be perhaps on Thursday and Friday. But we have a number of useful determinant frameworks, things like the Consolidated Framework for Implementation Research, the Theoretical Domains Framework, the Exploration, Preparation, Implementation, and Sustainment Framework, and a number of others that are useful at guiding evaluations of implementation determinants or barriers and facilitators. But I'll also note that a variety of methods can be used here. So anything from informal consultation to literature review. As the field evolves, we have an increasing amount of literature that really identifies barriers and facilitators. So you may not need to necessarily conduct your own studies in this space, but certainly oftentimes there's room for formal qualitative, quantitative, or mixed method studies that examine implementation barriers and facilitators. And really, I think the emphasis in the field moving forward is, can we develop nuanced theories of the problem? How and why are implementation efforts impeded? And how might we address those challenges with implementation strategies? Which leads to the third step of really selecting implementation strategies that might be effective, locally relevant, acceptable, and feasible to overcome those identified determinants or address those determinants. And then finally, how can we robustly and feasibly measure the implementation outcomes of interest, our more distal clinical and public health outcomes of interest, and any of the factors along the hypothesized causal pathway? So things like mediators and moderators that we might want to measure in our implementation efforts. I won't dwell on this too much, but this is from my colleague Shobha at Harvard University, who has a really excellent paper in this year's edition of the Annual Review of Public Health, where she and her colleagues demonstrate the use of participatory implementation science approaches really at each of these steps. So as we consider the types of implementation determinants that we're facing in a given context, as we're working to develop implementation strategies, as we're working to consider what are the mechanisms through which those strategies work, or the potential pathways here, And then as we're working to identify and operationalize our implementation outcomes, I think there are a lot of opportunities for participatory work, whether that's full on community partnered participatory research, or whether that's a bit more in the consultative space along sort of the spectrum of involvement. There are a lot of opportunities here. I just wanted to give one example. This might be a bit much coming out of nowhere, but wanted to give an example of how we might think about putting together a multifaceted implementation strategy, and one that might even be multi-level. This is taken from my colleague Sam Schilling, who's at the University of North Carolina. Sam is a pediatrician and a child maltreatment prevention specialist, child maltreatment pediatrician at UNC Chapel Hill. She has an effective intervention called PRI-CARE, which is a child maltreatment prevention intervention delivered in primary care. And one of the things that she found was that the real sort of linchpin in this process was referral to the intervention itself. She was struggling to get physicians to refer parents to this intervention. And so the actual ultimate outcome of interest that we wanted to change in this study was referral to PRI-CARE. The rectangular boxes that you see are implementation strategies. And you can see here that she used two strategies that she hoped would work in an accumulative fashion. So working at different levels to produce a cumulative impact on a factor like clinician motivation. So she worked through public recognition. She had basically a process in which she was monitoring physician performance and referral rates, and she was incentivizing that using a modest incentive like a Starbucks gift card. She also was using parent narratives, so people that had gone through the intervention to motivate clinicians to refer to this intervention. She also used a audit and feedback implementation strategy, hopefully to amplify the effect of those two strategies on clinician motivation by measuring performance, measuring referral rates, and referring and comparing that to their peers. She addressed parent motivation by preparing parents to be active participants in the intervention. She did this through a MyChart notification, so something in the EMR that was pushed to parents that really informed them about the intervention and hopefully improve their motivation. She hoped that clinician motivation and parent motivation would really work in a convergence, could converge to improve the parent-clinician interaction, improve their communication around this. And then finally, she used a clinician reminder that worked at the intrapersonal level to facilitate the effect of these implementation strategies on their ultimate outcome of interest, which is referral to PRI-CARE. And this was really more of a longitudinal quality improvement effort. And so this wasn't a randomized controlled trial. So don't, these aren't sort of like definitive findings. But she was able to show that they were that they could increase their referrals from 13% to 55%. And so really made a difference through the integration of these implementation strategies. And I should have said on the previous slide, this really builds upon work by Brian Weiner and colleagues in 2012 in a paper called In Search of Synergy. The idea here is that hopefully these strategies are being combined in ways such that 2 + 2 = 5 rather than 4. That they're actually hopefully boosting the effect of each other rather than sort of being put together in an unthoughtful way, or as we often refer to as the sort of the kitchen sink approach to developing implementation strategies, with the thought that more is better or more intensive strategies will be better. So I mentioned previously, I think I won't dwell on this for the sake of time, but that there are a number of different methods for designing and tailoring implementation strategies. So we've used methods like concept mapping, group model building, intervention mapping or implementation mapping, conjoint analysis, and the like. Heather Cahoon and colleagues at the University of Toronto have identified 15 papers. This was back in 2017 with replicable methods for this. Largely, these have similar steps as I shared through the French model, identifying barriers, linking those barriers to intervention components, and hopefully using theory and engaging end users. But there are a variety of examples of this. If you're familiar with intervention mapping or implementation mapping, this is really a long-standing method that's been used in public health. And essentially, it's an intervention development protocol. And these steps are quite similar to those steps that I shared for the French article earlier, so won't dwell on them. But I'll just say that we've used implementation mapping in a variety of different ways in our work. So this paper in the middle is from a study where we used implementation mapping in a really collaborative way with organizational leaders and clinicians from children's mental health organizations, where we were really trying to suggest that each organization has their own unique strengths and needs, and thus might need tailored implementation blueprints to more effectively implement programs and practices. And so we worked with organizational leaders and clinicians to engage in this implementation mapping process and really co-create implementation strategies. In a number of other studies, we've actually used implementation mapping to develop or refine our implementation strategies for large cluster randomized controlled trials. So the paper on the right is one example in Vietnam, led by Vivian Go and Bill Miller, where we used implementation mapping to develop a standard and a tailored condition of a cluster randomized controlled trial. So these are, I think, ways that can give you sort of a structured roadmap for developing implementation strategies. I think sometimes they can allay concerns of reviewers of your work if you don't have a complete sense of what your implementation strategy might look like. You might need to refine it further. Processes like this, I think, are rigorous and replicable processes through which we can do that. There are a number of other approaches. One is called evidence-based quality improvement. And this is something that's been advanced by Jeff Curran and colleagues in the Department of Veterans Affairs here in the US. I won't go over each of these steps in detail because, again, I think that these steps are quite similar across methods. But this is from a review of this method led by Terrence Swindle and colleagues. And one of the things that is helpful here to me is if you look at this column, I'm not sure how well you can see this on your slide, but if you look at the activities here for each of the steps, you'll see that a variety of different methods could be used for these activities. So for instance, for prioritizing determinants, they have, card sorting, numeric rankings, presentation discussion of interview findings, online brainstorming, a review of previous empirical research and guided discussion. So the way that you actually operationalize each of these steps might differ for your study. And in fact, I was really fortunate at one of the first Nisa meetings to work with HA and colleagues on an effort to do just this, is to sort of brainstorm barriers and facilitators and to sort of systematically document those. So there are a variety of methods that could be used here. And so again, I think perhaps one thing to emphasize is that there's plenty of room for increasing the rigor and relevance of these methods, but also plenty of room for creativity at this time and for tailoring these methods to your purposes. I've already shared a bit about causal loop diagramming, and group model building is really a system science based method for developing causal loop diagrams and developing a more complex view of how and why implementation strategies might work. So I won't maybe dwell on this slide, but this is just another example where we've used multiple methods within a given study. So in this case, this was led by Giselle Corby-Smith and Gaurav Dave at UNC Chapel Hill, where they used concept mapping to identify and prioritize implementation strategies. And they're using system thinking, if not formal group model building, to really think about the system-informed factors and how they might be addressed. There are a variety of other tools. I think, again, you've talked about the Consolidated Framework for Implementation Research, which is a framework that identifies a number of different implementation determinants or barriers and facilitators. This work is work that links the ERIC implementation strategies to the Consolidated Framework for Implementation Research, such that if you identified a particular determinant, we have a tool that would suggest potentially relevant implementation strategies. And we think that this tool has some face validity. It was based on expert input through a survey. It's definitely not perfect. It's definitely not based in evidence necessarily. It's really just based on expert opinion. But the idea is that if you identified a barrier such as low reflecting and evaluating, which is a process level determinant within CFR, strategies such as developing and implementing tools for quality monitoring, audit and feedback, and a number of other strategies listed here might be relevant for addressing that determinant. I'll also note here this paper by Yakovchenko and colleagues that suggests, despite what I just said about this being an expert-driven tool, they actually found that the recommendations generated by this tool were actually in fitting with real-world effectiveness evidence more often than not. And so I would point you to Vera's paper if you'd like to read more about that. I'll also suggest that Sherry and her colleagues, through some work funded by the Department of Veterans Affairs, are really working to generate a more evidence-informed tool that matches CFR and ERIC in a similar fashion. I previously mentioned the behavior change technique tool, and won't dwell on this, but this is another useful tool to match behavior change techniques to potential mechanisms of action. And you have the link here if you want to take a look, as well as the methods paper that guides that work. So I think for the sake of time, I might fly through some of this, but this is just to suggest that we have some evidence that tailoring implementation strategies, so prospectively matching implementation strategies to prospectively identified barriers, is more effective than standard implementation approaches. But it's not necessarily clear how to best tailor interventions, and not necessarily clear what the effective and optimally tailored intervention would be. This is from the 2015 review by Baker and colleagues. We're currently updating the Cochrane review on tailored implementation strategies. This is again led by Sheena McHugh at UCC. And we're excited. I think we've more than doubled the number of papers in the original review, and so should have some evidence emerging about the effectiveness of tailored approaches to implementation. However, as we embarked on this work, Sheena and colleagues really identified a number of conceptual and methodological issues in tailoring. And as simple as sort of how do we define tailoring? Sometimes it's just sort of the thoughtful design of implementation strategies, taking into consideration prospectively identified barriers. Other times tailoring means you're actually doing different implementation strategies for different settings or contexts. The sort of level at which tailoring takes place, the phases at which it takes place. So does it just take place prior to implementation when we identify barriers, or is tailoring an ongoing sort of more adaptive process throughout the implementation steps as increasingly implementation challenges are identified across the course of implementation? And then the methods that people actually use to tailor implementation strategies are often not transparently described. And so some of the more systematic methods that I mentioned on previous slides are meant to be sort of an antidote to that. I think there's increasing focus in the field about how can we think about adaptive implementation strategies. And so we might try one implementation strategy, and if it's effective, great. If it's not effective, how can we make informed decisions about our subsequent actions such that we improve implementation effectiveness? And so there are a variety of ways that this is happening. This is a really nice paper by Amy Kilborn and colleagues, where they talk about different types of adaptation in terms of both designs and interventions and strategies. But in terms of adaptive implementation strategies, we can think of approaches where we might start, for instance, with a more lighter touch implementation strategy, to basically conserve resources. If people respond to a lighter touch strategy, great. But if individuals or organizations or systems need more support, we might consider more intensive implementation strategies that more accurately address their needs. And so the idea of constructing adaptive implementation strategies, often through the use of novel research designs such as the sequential multiple assignment randomized trials and other designs, I think is an important direction for the field. Okay, and I promise home stretch here. There's increasing focus on mechanisms of implementation strategies. So again, not just whether or not they work, but what are the processes or events through which implementation strategies work to affect the desired implementation outcomes. And so thinking in a sort of using causal thinking and really mapping how and why our implementation strategies are supposed to work is, I think, increasingly important. And we have a number of tools that can help us to do that. In the U.S., the National Institutes of Health have really prioritized this in their calls for proposals for R01s, R21s, and R03s, and a number of other announcements, especially through the National Institute of Mental Health. This is far too simplistic, but just to give some examples of how we'd like to see this alignment between, determinants, strategies, mechanisms, and outcomes. We can take an example wherein we have a provider skill deficit. It might be that training or teaching and practice with corrective feedback is an appropriate implementation strategy that might work through the mechanism of skill acquisition, refinement, and mastery, and that would reasonably be linked to an implementation outcome like fidelity to an evidence-based practice. And to give an example at another level, turnover is a common challenge in healthcare and social services. We might use a train the trainer approach to ensure that real-time training and consultation is available, and that may work to improve an outcome like sustainment or sustainability. And so again, what we'd like to see is a logical connection between these factors. And as we think about the whole causal chain, how can we actually perhaps measure and specify some of these things to let us know, to give us early signs that an implementation strategy is working, or if the implementation strategy doesn't work to address these mechanisms, how might they be tweaked to address them better? We think that understanding mechanisms will really help us to better systematically design and tailor implementation strategies to make better decisions about how and why we should address these known determinants and achieve our outcomes of interest. We think that it will enhance our ability to learn from negative studies and replicate positive findings. We certainly think that this will facilitate the adaptation of implementation strategies developed in one context and taken to another, and sort of consistent with that notion, we think that mechanistic thinking really will generate a better understanding of generalizability and the role of context in implementation. If we understand how and why implementation strategies work, we can better pinpoint the types of contextual factors that are influencing those mechanisms, and hopefully generate better learning over time. So there are, as I mentioned, a number of ways of documenting this. We've used a causal pathway diagramming approach in some of our work funded by the NIH. So this is work led by Kara Lewis, Brian Weiner, and others, wherein they've really worked to specify moderators, mediators, and sort of more proximal and distal outcomes that are relevant to implementation. And so there's actually a full toolkit that was developed in collaboration with a number of NIH-funded studies that you can access at the link below. And I would highly encourage you to take a look at that if you're interested in this approach and wanting to think about how you might use it to specify your implementation strategies. I think I won't dwell on this slide. This is just further sort of reasons for why we might use causal pathway diagrams, and implicit in that, why we might think about mechanisms at all in terms of things like helping us match implementation strategies to determinants, measure strategy functioning and diagnosing why an implementation strategy did or did not work as intended. But I think a really helpful table from Pedja's recent paper in Implementation Research and Practice. We have a ongoing work where we're taking commonly used ERIC implementation strategies or other implementation strategies and specifying causal pathway diagrams for each of those, basically developing plausible theories, hopefully plausible theories about how they work. And we're also developing measures of implementation mechanisms and ultimately generating a web-based knowledge repository that will be used to advance our understanding of mechanisms in implementation science. This is just another example of a different way of thinking about this that's similar to causal pathway diagrams, but is really based on if there are epidemiologists in the room or others that are familiar with directed acyclic graphs or DAGs. This is really a DAG-based approach that helps us to think about how and why our implementation strategies work, what are the contextual elements that might influence strategy effectiveness and the like. And this is taken by a paper that Elvin Gang, Anna Baumann, and myself wrote in response to a null trial that found knowledge brokering implementation strategy did not have an effect on evidence-based staffing in a hospital setting. And we use this approach to suggest some reasons why and some reasons why it might be helpful to think about mechanisms as we think about implementation trials. This might also be familiar to you or to those of you who are used to sort of logic models or used to the implementation research logic model or the like. This is from work from Lydia Kwok, who's a colleague at Karolinska in Sweden. This was actually another null trial that was, we had a chance to do better the next time. And so she actually used the previous findings to be more thoughtful about the mechanisms through which her implementation strategies work, and to really consider how she might design a better implementation strategy. So in this case, she specified these implementation strategies for a guideline to prevent what they refer to as mental ill health in the workplace in Sweden. And she specified a number of hypothesized mediators here that were specified according to the theoretical domains framework and measured using a theoretical domains framework questionnaire. And so I think a helpful way of being explicit about how and why these implementation strategies can work. As you can see here, sometimes a single implementation strategy might address, multiple mediators or determinants, and that's well depicted here. I already mentioned, I think, the potential benefit of system science approaches. This is a recent paper by Doug Luke, where we examined a number of case studies and hopefully made the case that system science methods are actually particularly useful for understanding complex mechanisms in implementation science. So would urge you to take a look at this year's version of Annual Review of Public Health to see that paper if you have interest. Going to skip over that one, and then just to suggest, I think thinking about mechanisms also is really useful in helping us to anticipate potential negative unintended consequences of implementation strategies. I think this is really great work by my colleague Mike Pullman at University of Washington, who suggested negative and positive unintended consequences of implementing evidence-based practices. So we often think that implementation is a great thing and that people should be jumping up and down to implement our evidence-based treatments. But we know, for instance, that it can lead to things like emotional labor, data gaming, where people might say we're actually doing better on implementation practices than we are, treatment counterfeiting, where we might say we're giving a specific treatment when we're actually not, tremendous administrative burden and other opportunity costs. But we also know that there are positive unintended consequences. So we might have things like job retention or improved morale, the improvement of the quality and sort of treatment as usual, or even the use of evidence-based practices for self-care or for family members. And so specifying the potential mechanisms through which implementation strategies work is important, and a natural extension of that is to, can we start to anticipate some of these ripple effects or unintended consequences of implementation strategies? And don't have time to dwell on this, but this is a great paper by Catlow and colleagues who suggested a dark logic model of audit and feedback. So using audit and feedback in a medical setting and demonstrating a number of sort of unintended consequences in a negative way of that. And so a useful way of a different type of logic model that you might use to examine how and why implementation strategies work. I think just a few more slides from me, and then I will hand it over. Sorry if I'm going way over. I mentioned sort of the challenge of reporting in our field, wherein we often don't necessarily know what people did and why they did it. And so we have this notion of even if an implementation strategy works, we don't know how and why it worked. If a strategy doesn't work, we don't necessarily know how we would fix it. And so this issue of poor tracking, specification, and reporting has been sort of long-standing, and we have a lot of work to do to try to do better on that front. Hopefully, we're getting better over time. This is from some recommendations that Enola Proctor, Curtis McMillan, and I put forth just over a decade ago now, where we really are trying to encourage people to name implementation strategies using language that's consistent with the literature. So one way you can do that is to think about like the ERIC compilation, the behavior change techniques, behavior change methods, other established taxonomies in the field to name implementation strategies. We ask people to define their strategies operationally, and then importantly, really specifying their strategies in detail according to who are the actors involved, what are the specific actions that they're taking, what is the action target that you're actually addressing. And here's where, again, a lot of the conceptual frameworks that we use in the field, such as some of those that you've covered this week, could be important in specifying sort of conceptual targets through which the implementation strategy is working. This also fits really nicely with the idea of mechanisms here. Is there anything about the timing or dose of the implementation strategy that needs to be reported? And then what are the implementation or other intermediate and distal outcomes that the strategy is addressing? And then finally, what is the empirical, theoretical, or pragmatic justification for why these strategies were selected, why they are likely to work together synergistically, and the like? And so we hope that if you have a multifaceted implementation strategy, you actually report each of the included strategies using some conventions that are like this, or that are at least similar. And this will go a long way in ensuring that our implementation strategies are replicable. Along those lines, we're increasingly focused on, just like we care about fidelity for clinical treatments or public health treatments, there's an emerging focus on fidelity to implementation strategies and ways that we can improve that. Chris Akiba at Research Triangle International has done a lot of great work in that space. And then the notion that implementation strategies are likely to change as challenges emerge, as new issues evolve over time. And so this is a paper from Amber Haley where she really tried to emphasize the importance of first describing planned implementation strategies, but also tracking strategy use over time. And as barriers and solutions emerge, we may need to note modifications to planned strategies. So we might be dropping strategies, adding strategies, or modifying or adapting implementation strategies over time, but that we really need to describe that just like we would describe and report our implementation strategies at the beginning of a trial. And just to say, we're working on more pragmatic ways of doing this. J.D. Smith has some methods in this space, and a lot of the methods here listed below on the slide are efforts to do this in a more systematic and pragmatic way. And I haven't talked a lot about implementation trials, but wanted to point you to what I think, I'm biased, but what I think is a really good paper by Luke Wolfenden and colleagues in BMJ, which is really meant to be sort of a field guide for designing and undertaking randomized trials and implementation. I think also does a really nice job of covering things like hybrid effectiveness implementation trials, some of these specification standards that I'm suggesting, and other factors. So I will hand it over at this point, maybe with a final commercial for implementation research and practice. If you're not familiar with our journal, this is a journal that we publish in partnership with SAGE and the Society for Implementation Research Collaboration. And especially if you are in mental health, substance use, or behavioral health of some kind, and doing implementation research, would love for you to submit to our journal. So please explore the website for more on that. Again, sorry for going over time. Thanks so much for your time today, and looking forward to learning from Dr. Alakunde and from your questions and discussion afterwards.
Thank you so much, Byron. Thank you so much. So over to you, Yemi.
Thank you very much. Can you see my screen? Slide.
We can
Yes, we
hear
can.
you and we can see.
All right. Okay. Thank you very much, Dr. Powell, for that lovely presentation. I was taking notes. I learned a lot from that. Thank you so much. It's always good to be on the panel with. Can you hear me?
You're drawing back. You
Yes, we
echo a
can.
little
Loud
bit.
and clear.
Okay. All right. So I was saying that it's always good to be on a panel with experts such as Dr. Paul. So when all the difficult and technical questions come, they can be directed to him. So Professor Tonia, please take note.
Okay.
Anyway, so my presentation today will focus on how we've utilized the HERIC strategies in our ongoing grants in Nigeria. And I think Paul has laid a very good foundation and background for what I'm going to be talking about. So our study is called ACCESS. It's the accelerating survival cancer elimination through integration of screen and treat services, or ACCESS for short. So it's a NIH grant, a U01 grant. The principal investigators are Greg Aarons of University of California and Professor H. Zona of our director at Ivan Research Institute. The grant is being implemented in 12 out of 21 what we call the Nisa Model Innovation Research Centers. If you were here yesterday, Dr. Olarapo spoke extensively about the PBR network. The Nisa makes a part of that network. They are, high volume sites that we've designated for clinical and implementation research in Nigeria. Okay, so this slide is just showing, this map is showing where the sites are located across the 6 geopolitical zone. You can see two in Gombe State, that's the northeast, two, one in Kaduna and one Katsina in the northwest. So the stars are where where the sites are located across the geopolitical zones. The paper beside it, it's where it's published in BMJ Global Health, where we describe the Nisa mix, how the sites were selected, and how this infrastructure that we've built, for multi-center clinical research across the 6 regions of Nigeria. So you can read more about the infrastructure on this paper. So most of the things I'm going to talking about today, I'm taking from these 2 papers that we've published. The one on my, on the right or left. The first one, the rapid implementation mapping, which Dr. Powell also mentioned. we describe in that paper how we identify the implementation strategies that we are implementing in the access study. Then the second one is a protocol, where we also described our study design, what access is all about, the procedure and implementation outcomes, and how we're going to be measuring them. So you can read more about the process implementation mapping and the protocol on these two papers. So why access? Cervical cancer is the second most common cancer among women in Africa after breast cancer, and it's also the second leading cause of cancer death. But when you compare the general population with women living with HIV, the women living with HIV are at increased risk. They are more likely to, acquire HPV infection and also develop cervical cancer. Some literature put it to 5 to 6. They are 5 to 6 times more likely to develop cervical cancer, and even more likely to develop it at a younger age. One of the reasons is that because of their weakened immune system, they are find it difficult to clear the infection, HPV infection, when they're infected. And also some studies have also indicated that HIV can enhance the oncogenic effect of HPV. So they are at increased risk of cervical cancer. However, we know that cervical cancer is preventable and curable if diagnosed and treated early. One of the ways of preventing is through vaccines, HPV vaccines, for primary prevention, which is currently available in Nigeria now. But even if you've been a woman that has been vaccinated, is still expected to undergo regular screening, because the vaccines do not cover all the vaccines available do not cover all the different types of HPV. So there are some that can still cause cervical cancer that are not covered by the vaccine. So cervical cancer screening and treatment service is evidence-based intervention, which is very critical for preventing cervical cancer. However, studies have shown that there's low screening rates, particularly among women living with HIV/AIDS. In Nigeria, studies have found less than 10% of women living with HIV/AIDS having cervical cancer screening. Also, we've found that in literature, if you integrate, public health interventions for moving to like routine HIV care, it can improve, uptake or coverage of those interventions. But for cervical cancer screening and treatment services, there is, we know that if it's integrated into routine HIV care, it can improve uptake, but there is at a point where we didn't find evidence on, effective implementation strategies, that can enhance this integration of cervical cancer screening into routine HIV care. So that was the background, for our study. And our aim was or is still ongoing to identify and also test if the effectiveness of implementation strategies that can increase cervical cancer screening, on-site treatment of precancerous lesions, as well as referral for suspected cancer among women living with HIV/AIDS. So that's our overarching aim. We have three three specific aims. And the first one is to refine, strategies to integrate cervical cancer screening and treatment and services within existing HIV treatment program. So prior to the grant application that began, we conducted, I was to speak more on this, we conducted the implementation or intervention mapping to identify the determinants as well as implementation strategies to improve cervical cancer screening and treatment services. So when we apply for the grant, our aim one, Byron talked about, refining and tailoring strategy. So our aim one was we focused on aim one on refining or tailoring those implementation strategies that we identified in our exploratory phase of the study. So for that aim one, we conducted focus group discussion with implementation research teams. So these are healthcare providers implementing cervical cancer screening in the health facilities, and we wanted them to look at those strategies and see how it can be tailored or refined to suit the particular context that they will be implemented. So that's the focus of our aim one. So for aim two is where we aim two focuses on testing those implementation strategies. So we have what we call the core strategies, and we have what we call the core plus implementation strategies. So some facilities were randomized, and 6 facilities to the core, and another 6 to the core plus implementation strategy. As I mentioned earlier, we are currently we are implementing in 12 health Nisa mix facilities. Now I'll speak more about the core and core plus implementation strategy later. So for aim 2, our approach is a cluster randomized hybrid and type V trial. We are interested largely in testing the implementation strategies, so not on the effectiveness of cervical cancer screening and treatment. So that's why we went for type 3 trial. And we for our outcome, implementation outcome, we're using the REAIM framework to as our evaluation outcome. And so we are looking at reach, which is the screening rate. Our adoption is the uptake of CST by healthcare providers as well as health facilities. For the fidelity, implementation fidelity, we're looking at fidelity of the implementation strategy as well as fidelity of the clinical intervention. While for our effectiveness, we are not testing that, but we are, of course, collecting data on that. We are looking at how effectiveness of CCST, and by that we are measuring negative screening after treatment for pre-cancerous lesion. So that's our aim to what we are, where we are testing those implementation strategies. So for M3, we are our team is focused on looking at sustainment of the integration of CCST into the HIV program, and for our approach for M3 is to conduct mixed method. It's going to be a mixed method design to both survey and focus group to see how the integration will continue, after the implementation of after the research. So that's what M3 is focused on. So in addition, we are also looking at moderators. I think Dr. Paul also mentioned this in his presentation. So these are factors that may increase or decrease the level of influence of the implementation strategies on the outcomes. So we're looking at organizational readiness, implementation climate, implementation intentions, and self-efficacy. So for this factors, we are using so we collected data and at baseline using tools that have been validated, with good psychometric properties to assess these potential moderators. So for this study, we are using 2 frameworks, the EPIS and the REAIM. I've mentioned REAIM. That's what we are using as our outcome or evaluation framework. But we are using EPIS. We selected EPIS because it's useful in guiding implementation in different settings, including low and income country. So it's both a process and determinant framework, which describe 4 phases of implementation process: the exploration, preparation, implementation, and the sustainment. We are also considering the using it as well to look at determinant for the determinant for implementation. So both the outer context, inner context, and the bridging factor, as well as the innovation factors. So in the exploration phase, and that's the phase that I said we conducted, before our aim 1, and that's where we really identified the implementation strategies that we are implementing on this for the access study. And so it's where we conducted the implementation mapping and co-created those strategies with stakeholders. So I'll still speak more on that, I think, the next slide. So the preparation phase is where our aim 1 is really where we're implementing our aim 1, which is to refine and further tailor those implementation strategies identified in the exploration phase. The implementation phase is where we're testing those strategies and also collecting data on the outcome. And while the sustainment is where we'll look at the sustainment of the intervention. So let me. Okay, so this is a table or figure, from the intervention or implementation mapping that were conducted in the exploratory phase. Like I said, the papers is we published the paper and it's available. You can read more about it, but this is just a summary of what we did. Apologies if it's not so clear, but I can just run through it. I have some in my notes here, so I don't forget. Right. Okay, so Byron mentioned implementation and mapping as one of the ways to stepwise or systematic way of developing or selecting strategies to increase the adoption or implementation and sustainment of evidence-based intervention. There are also other methods, like you mentioned, the conduct analysis and concept mapping, as well as group model building. I think on Friday, we will be talking about group model building. But for us, we conducted implementation and mapping to identify these strategies in our exploratory phase. And the first thing we did was, to even do what we call more like the needs assessment, just to find out if what we are proposing is actually really the gap that we identify in the literature is really really there, and if what we're proposing is really important, and just to find out if it's something that people think is an issue that needs to be addressed. So that needs assessment was done, and the second phase for us was to get the determinant, right, for implementation, determinant barriers and facilitators affecting the implementation of cervical cancer screening and treatment, as well as the implementation strategies. And to be able to do this, we conducted like a survey, online survey, which reached out to implementing partners supporting cervical cancer interventions in Nigeria, I think 5 of them. So we asked them to identify 3 major determinants, affecting cervical cancers screening and treatment. And for each determinant, we also requested and that they mapped link them with strategies that can address those determinants. So we asked them to list 3 to 5 strategies that can address each of the determinants that they've identified. So we sent the paper that Ryan also showed earlier in his presentation. We sent it to those to the respondents, right, to look at those strategies listed in the paper and to be able to select the ones that they think can address those determinants. So when we got the feedback, we compiled, the research team now compiled the determinants. I think after we removed duplicates and all, we came to about 10 unique determinants. So the second phase after that was to do the NGT, where we ranked and also voted for the determinant as well as the implementation strategies to address those and determinants. So for that phase, it was a virtual meeting. It involved the implementing partners as well as healthcare providers providing cervical cancer screening and treatment services in those health facilities. So in the first phase of that NGT, what we did was to again look at those and determinants as well, so that everyone will everyone had a common understanding of those barriers. So that was the first step. And the second step was to now ask them to rank the top three barriers from the 10. So each participant ranked, and we had the top three barriers from the 10 determinants. So the next step, of course, in looking at that, we asked them to look at those, rank them based on their how important those barriers were in determining uptake of cervical cancer screening and treatment services. So following that, we now ask them to also for each of the determinants, rank the top two strategies from the pool of strategies that we got in the first phase, to rank the top two that can address those determinants. So they did that as well. So we, at the end of the day, we had three strategies and six implementation, three determinants and six implementation strategies to address those determinants. Of course, recognizing the limitations of the ERIC strategies or ERIC compilation, we asked the participant to also, consider maybe any other strategies that may be relevant, right, that are not in ERIC that could address the determinants that we were looking at, the top three determinants, right? So we asked them to consider strategies that will be one can be implemented across board in a different context or different region, strategies that will also address at least one or more determinant, not specific to a determinant, that can address one or more of the determinants, and of course a strategy that is feasible and will have good impact. So we asked them to also identify that. So they identified, I think, about five strategies, which were not originally in ERIC, and at the end of the day we also voted for the top two out of those strategies. I think we had a tie into I think the second and the third strategy were a tie, so we blended that strategy at the end of the day. So that's how we identify those strategies. At the end of the day, this is what an outcome of that process, the implementation mapping. This is what we have. So what we had from that process, the ones in red are the determinant, the top three determinants ranked by the participants. So you can see human resource capacity gap, poor access to cervical cancer services, and low demand for services from lack of awareness about cancer and cancer services. So those were the three visual determinant ranked by the participants. And you can see the blue ones are the ERIC strategies matched. So each of the determinants. So you can see, for example, used train the trainer, conduct educational meetings, involve patients, consumers, and family, etc. So those were the ERIC strategies. Then the ones in green are the additional strategies identified that were not, from Eric. So we have the stakeholder/community engagement through HBI. That's the one that we combine two strategies. So the first one is the HBI, and the second one is stakeholders engagement, which we blended together, and the other one is the material development plus translation. So initially, so at this stage, the strategies that were the blue strategies were what we classified as the core strategies. So those are strategies that were largely from the ERIC compilation. Now this changed along the line though, but that's what we classified as the core strategy. While the other additional strategies were what we call plus the core strategies. So the additional strategy plus the core strategies, what we call the core plus strategies. So the core strategies were the 6 ERIC strategies. The core plus strategies were the 8 strategies. So the ERIC plus the additional 2 strategies. So like I said, aim 1, again, was focused on refining and tailoring those implementation strategies. So after that process, we continue and speaking with stakeholders. We'll also reflection, the research team reflection on those strategies, and we kept refining those strategies, even with the focus group discussion that we had with the implementation research team. So what you see, this last column, the refined strategies, were the final strategies that we are implementing in the on the project. So at the end of the day, we have 7 strategies in total, which are we have 5 in the core and 2 in the core plus. So the core now, based on our refinement, they are not entirely from Eric's strategy. So we have additional strategies added to it. For example, like strengthening the referral system. During the refinement, we understood that we didn't have any strategies, really addressing that component, which is quite important. Referring women that have been that are suspected cancer to the next level of care. So we had to add that strategy to it in our refinement. I think at the end of the day, we only have I think we just have about 2 or 3 strategies from Eric in the core implementation strategy. That's the providing ongoing consultation, conducting educational meeting, and preparing patients to be active participants. So those are the main strategies in the core plus from Eric that we are still made it to the final list of our implementation strategies. For the core plus, which also include the core and the additional 2 strategies, not necessarily from Eric, the community engagement through HBI, as well as engaging patients using our ML platform. So of course, we also went ahead to in the protocol, really like Paul mentioned, Dr. Paul mentioned, to name and define the implementation strategies. So for each of the strategies, we have the operational definition, and we have the actors and people that will be implementing it, as well as the action and who the strategies targeted at. The dose or the frequency of implementation of implementing the strategy, as well as the mode of delivery, if it's going to be virtual or in person. For example, we can see that in the core and core plus, we're implementing conduct educational meeting, which is to hold our operational definitions to hold meetings among healthcare providers to improve CCST's service provision. We can see so the actors at the site, clinical teams, we're implementing this strategy. And what they're expected to do is to conduct site clinical review meetings, on CCST cases and look at number screen and today. So it's like audit and feedback, but a bit different from it. Another one is they maybe strengthen the referral system. So we define it as to facilitate referral and easy navigation at referral centers to ensure women that are referred for suspected cancer, complete the referral. And it's to be implemented by the site clinical team. So they are the actor for that. And the action also identify and prepare individuals and referral coordinators to track and support easy navigation at the referral centers. So we did that, for all our strategies that we're implementing in both the core and the core plus. So these are the first five that I mentioned are the core strategies, which we're also implementing in the core plus, and the additional tools, strategies that are only restricted to the core plus. For example, we strategy which we named as engaging patient using ML platform. We define it as using patient health and smart card, which we've demonstrated in our previous study to be quite useful and acceptable by patients to record CCST services and to also track and send appointment and reminders. And this is to be implemented by both the research team as well as the clinical team. And the action for that, we also describe it as to, scan patient records on the card and also to send an appointment reminder to patients. So we named, apart not just identifying those strategies, we also try to name and define and operationalize them in our protocol. I think this is my last slide. So what lessons did we learn, from using Eric to identify and to identify our strategy first? Like Dr. Powell mentioned, facilitated the identification of implementation strategy. So we had like a list that we could share, with stakeholders to select to select from, and it makes the the nomenclature and times of and names of those strategies to be consistent, across board, and also it informed and helped us in defining and describing the implementation strategy. Although we did this operationally, but because we had some guide presented in the paper, so it helped us in defining our strategies. I must say that the list, like Dr. Fowler said, is not exhaustive. So we recognize that. That's why we give opportunities, for stakeholders to also go beyond the strategies that were listed in the paper, and identify things that will be useful for our contest. Can also be time consuming. I think there are like 73 unique strategies in that paper. So if you had to go through 73 and match them with each of the barrier, and it depends on how you go about it, right? And can really be time consuming. So what I do is I pick, if I'm using this one, I look at the strategies. I look at the strategies first, then look at the barriers. So I don't look at the barriers and then go through the 73 strategies. That can be a bit time consuming. But by and large, we found it very useful in helping to select and identify implementation strategies. At the end of the day, I think we have just about three that we included or implementing in our project. Thank you. I think that's my last slide. Just want to acknowledge Dr. Bembe and Dr. Stanley and Mr. Stanley Ene. Those are the people involved in day-to-day running of the access study, as well as our research, site research coordinators on ground in the health facilities, and also acknowledge the MPIs and my fellow cohorts. Thank you very much.
Thank you so much. Thank you so much, Yemi. Thank you, Byron. Right now, there are no questions in the Q&A, and I know what they say when there are no questions is either you guys have super saturated us with information or the reverse. I won't say what the reverse is. Okay, but a question popped up in the chat. Says, I think that question is for Byron, and it says, can you give a typical example of how fidelity is measured as an implementation outcome?
Yeah, so I don't know about typical example, but I think it's actually the same challenges that we face in measuring fidelity to clinical programs and practices, and that there's sort of a tension between the level of rigor and sort of how pragmatic it is. And so sometimes when we've measured fidelity as a primary outcome, we've used things I mean, for clinical outcomes, we've sort of debated, like, do we record sessions? Do we use self-report? I think for implementation strategies, some things are much more structural and can be measured more like it's either present or absent, or in a much more simple way. But other things might be quite more behavioral. So, like for something like implementation facilitation, for instance, I know colleagues at the VA have been thinking about, like, what are the interpersonal skills that facilitators use, and how might you think about components of specifying components of effective facilitation. For most of our implementation strategies, this is not very well specified, because even the strategy itself is not very well specified. So I think it's more of an aspirational example for many folks, and some of the examples that I presented on the slide from Chris Akiba, some of the interviews that we conducted around assessing fidelity, some people said, like, the best we could do right now is track implementation strategies, given that oftentimes, like Dr. Alakunde said, he has a number of different core and additional strategies that he's assessing in one study. And so it can get quite complicated fast in terms of the number of things you're assessing.
Okay, thank you. So I'm going to hand over to the director for the Ivan Research Institute, Professor Echezona Ezanolu.
Thank you so much, Baron. So I'm going to start with my own question. Because there is something that everybody has talked about, the ERIT strategy. For me, when I started implementation science, and one of the most confusing things for me was how to define it, how to name it, how to make sure that we are speaking the same language. So I think for me that the ERIT strategies were one of the most important papers in implementation science, because it made us speak the same language. I'll give you an example. You'll be talking to someone and say, how did you identify this problem? They say, well, we gathered a lot of people in the room, opinion leaders, and then we asked them what they think are the barriers. And so I said, oh, so you did a focus group? No. We gathered people in the room and we asked. I said, that's called a focus group. So you find out that people have done a lot of these things, but they don't actually know that the name is done. And I relate that back to my own career, where I did not know what implementation science was until I was at NIH and I was supposed to meet 4 program officers. And one of them said, oh no, your career has been scattered. You're jumping from sickle cell to hypertension to HIV to MRSA. You are all over the place. Then one of the program officers said, look at what he's doing. He's all over the place. But everything that he's doing in all over the place is all implementation science. And I turned to him and said, what is that? And they all started laughing. That is how my own career started in there, to realize that what I've been doing has a name called implementation science. Even though what attracted me was my belief that if we can implement what we already know, the evidence-based intervention, we already know that we can solve 80% of the problem in LMIC. Nothing new. So our problem is not because we don't have something to do, it's implementing what we already know. Papers come out, it takes 17 years to become part of policy. People come to Nigeria, they work, they publish it in Lancet. The people in Nigeria didn't even know that work happened in Nigeria. That was one of the things that drove us to, you remember the first time, to form the Nigerian Implementation Science Alliance. The idea is that if you conduct research in Nigeria, you have a platform, not just at the international meetings, but in Nigeria, in Africa, to be able to present the result you have of what you have done, instead of waiting for people to read it in Lancet. But one of the challenges that have come Eric's strategy is that at the time that it was done, there was really, as you will acknowledge, no contribution from the LMICs, at least meaningfully. Most of them were North America-based and HICs. So, but there is something you talked about today that caught my interest. You talk about refinement. You talk about, being able to add to it. How should teams that are in LMICs that have comfortably used the ERIC strategy in many of their projects have something to add, have something to contribute? How do they go about doing that?
Yeah, it's a great question, and I think maybe a couple of thoughts. One, I mean, I suppose there's some tension between, like, should you have to refine or adapt an existing taxonomy versus, starting and developing something de novo from certain contexts. And so maybe that's one question. I think in a broader sense, we don't do enough of this with any of our frameworks in implementation science or any of our tools. So I have a colleague, Kate Livero at Columbia, who says tools, not rules, right? And I think rather than that, people sort of take them as sort of law, like these are things that we should be using with fidelity, or like they're sort of more written in stone than they are. And I think as a result, what we have is a lot of papers that use things like ERIC or CIFR or EPIS, and they don't sort of push and sort of challenge them. And so I think the first thing that you can do in terms of how do we do that is, if you use an existing framework in your work, be very transparent about how you used it, how it was helpful, but also how it was not helpful, especially if you can do so in a constructive way and say, here are the ways that it was not helpful, and here's what we suggest, could be added, could be supplemented, or even, hey, we tried this and it didn't work at all, and it's building the case for the need for an entirely different taxonomy or framework. Like, I think those arguments need to be sort of made and hashed out in the literature, and I think people should be more bold in doing that, rather than sort of like, I think it's important to be conversant in the literature and to be aware of things that already have been developed, so that we're not recreating the wheel. But I also don't feel like we should be beholden to maintaining those tools if they're no longer useful.
So if I ask it in another way, to say, if I said we have used, and I mean we in Nigeria, from Nisa, we have used the ERIC strategy in 5 major projects. We have used the EPIS framework in 5 major projects. If we were to put our experience from actually using this, do you think that would be contributing to the literature?
I certainly think so, as long as you can do it in a systematic way. And I mean, it's always, of course, a challenge of finding, like, what's the right paper type and what's the right way to make that argument. But I think if you feel like you have, I assume you have many lessons learned from both frameworks across that, I think that would be a great contribution to literature.
Thank you so much.
Okay. Yeah. Thank you, Byron. 2 more questions.
I saw there are more questions, so I will leave mine until after the 2, then I can come back. All right.
Okay. Okay, so the first one from Dio. Dio says, are there any differences between causal pathways diagramming and theory of change frameworks, or are they the same?
It's a great question. So I think to answer specifically and more broadly, like, I presented a number of ways of sort of trying to understand causal processes in implementation science. We have speaking of a contribution to the literature, we have an idea for a panel that we keep presenting to CERC and DNI. It keeps getting rejected, but for like a rap battle between different ways of presenting causal processes in implementation, because some of my colleagues, for instance, I mentioned the colleagues that are using causal pathway diagrams, and we're doing that in some of our studies. Some of the colleagues that are more drawn to the DAG approach sort of have some critiques of the other approach. In my view, they're all just like different tools that probably have similar purposes and probably trade-offs, like pros and cons. And so I try not to, at least personally, I try not to get sort of like too caught up in you have to use this tool and not this kind of tool. So if you're comfortable with developing theories of change, I think that's exactly like the spirit of what we're doing, is trying to understand how and why an implementation strategy works, just like we have understood how interventions work. You know, like, this isn't exactly a response to the question, but like for logic models as we've traditionally used them, I mean, sometimes if you have seen logic models where we have large columns and it's sort of like all these things are related to all these things are related to all these outcomes, I think one of the things that some of this causal thinking is doing is helping us to make those horizontal links and be much more precise about what is linked where. So I think to the extent to which your theory of change work does that, I think that's helpful, more helpful than sort of coming up with broad links between sort of processes, outcomes, and the like.
So his last question is, how can we use or blend group model building with logic models or theories of change frameworks to clarify determinants and identify strategies and ensure that implementation outcomes are captured along with patient outcomes?
Yeah, it's honestly, it's sort of the same approach. So, sort of the same response is that, like, and maybe to say it a different way, like, I think you could have a group model building session and a causal loop diagram that is sort of simplified into a logic model, you know, and they might be sort of useful for different purposes. So, and same for causal pathway diagrams. Like I put up the work from Lydia Kwok that showed sort of a logic model that's used in her study. She's also used causal pathway diagrams as she's thought about how these different strategies worked and sort of played with that method. So in my view, they're all sort of both methods to sharpen our thinking about how and why these things work. So like the exercise itself is not as easy as you might think, right? Like it's sort of, I think you have to start somewhere, and in my view, it doesn't have to be perfect. It's really a way of sort of pushing our thinking and helping us to articulate how and why strategies work. And I think that the methods that we use to communicate that to other people might be different depending on the purpose. So again, what might fit in one grant application might be different than what you fit in a manuscript, might be different than what you use internally with your team. And so I think the different tools could be useful in different purposes. And I'm really glad that you have Ellis Ballard coming to talk about group model building. I think he might have thoughts as well about sort of, you know, how to translate that. But in my view, they're all just tools that could be used in complementary ways.
Okay, thank you. So Prof, over to you.
I have another question. So one of the things that increasingly people are discussing about is how to do implementation science and how to design implementation science with an equity lens in place. So, and I know you touched about it on one of your slides about, you know, trying to build how do you really look at your designs, at your implementation with an equity lens in a way that that both as you're formulating the protocol and as you are implementing and carrying out the program, how do you make equity an integral part of that, both your design and your implementation process? Yeah,
it's a great question. I certainly have many colleagues, you included, who are more experts in this than I. So I might bounce it back to you. I mean, I think it's I think I've even heard the term equity lens critiqued as if that's like a, you know, like an add-on. And I always, especially when I present, I always feel like I'm at risk of sort of like having it just be like a side mention and not really a focus. I mean, I think some of the systematic approaches that I've presented for developing and tailoring implementation strategies in my mind, can and should center equity in each step of the process, right? So it's like one, like a lot of implementation is about understanding context, understanding determinants, understanding what's going on, and really having respect for the problems that we're facing. And so if we're trying to understand a theory of the problem of why implementation challenges exist, part and parcel of that to me would be understanding equity issues that might underlie things. Is that sort of maybe the evidence, even as we start with sort of like the evidence base for different practices, sometimes the evidence base is quite uneven, right? For maybe we might have evidence for that there's evidence-based practices, but they've mostly been tested amongst homogenous populations and more wealthy areas of the U.S. or something like that. And so I think even interrogating the evidence base and evidence base for whom and asking those questions is an important step of the process. But I think as we move towards these sort of like, stepwise processes that can be time consuming, I think asking equity questions along the way about who's included in this process, who's excluded from this, how can we ensure that everyone has equitable access to care through our implementation efforts. It may suggest the need for tailoring for different contexts, different settings, different populations. And in a way, I think the sort of more tailored adaptive approaches to implementation are well suited to those types of questions and interrogations. But yeah, I would love to hear what you think or what others think either in the chat or online.
It's flattering to think that if you think of people who know about equity, that you count my name. But the truth is that you can see from the response from Helen that I don't know anything that much about it. That first of all, I'm looking at it with a lens, and she's saying you shouldn't look at it with a lens. And for those of people who are on attendance today, Helen Scottoris from Australia. She's from Monash University in Australia. She's going to be with us tomorrow, and she's going to be looking at this. So I'm looking forward to learn more because it's important to think about equity, not just like she corrected me, not just as a lens, but throughout the whole process and as a process. So when you are designing it, when you are implementing it, when you are conceptualizing it, but to have an equity, for me, I thought of lens as you are looking at all of them, but she said it's more of a process. So please be here tomorrow. I think we can all learn a little bit more about how to make sure that equity is integrated into our thought. Thank you so much, Baron. And I am grateful for all you have done for the Nigerian Implementation Science Alliance and for all you have continued to do. I want to say a special thank you because whenever we have called on you, whether it was an advice for a grant or to help out with a paper or look at something we have done, you have always been there for us. So thank you so much. And we hope that you truly will come back to Abuja and come back again. So we're extending that. This year, we're having the meeting in collaboration with the Global Implementation Society, GIS. So please feel back to come back. You always have a spot on our panel if you choose to come. We'll be happy. If you're not coming this year, the next year, I'm going to try to drag you because it will be our 10th year anniversary. So it will be nice for you to come back. But thank you so much. And I have one question for Yemi, because one of the things we have talked in our team is to say, if we're going to use ERIC strategy in selection of our strategies, is there a place that we can really take what we have learned from, because you did talk about something that I haven't thought of, which is how to create a strategy. You talked about the process to actually, I never thought about that. So I think it's something that we're going to learn. So I want to point this back to Yemi and said, if you were thinking about things you have done with Eric, how will you go about trying to create a strategy that you can say, this is something that they may, because people say, well, there was no representation from LMIC. It's not about representation. It will be more about contribution. So if you're thinking about it, you might see that you might want to see if there are new things that were not included in the ERIC strategy that are being seen as people use ERIC strategies in the LMIC, that they can develop that. So how will you think about that as you implement you have a 5-year project going on now? How will you try to look at the implementation you're using? And maybe it's a referral, maybe it's all one of those things, but how can you use it to create and define a new strategy with the experience you've had? Thank you.
A great question, Prof. For me, I think what is important in doing this is to be a bit systematic, about it. And I think there's been for example, the GO1 grants that we're implementing, a number of countries or okay, a number of people also as well implementing the Euro One grant. So it might be, coming together as a team and just see what have we learned, from this process. I think also going to the literature. So there's been increase in the implementation research is growing in Africa and low income countries, right? And just see what people have been using, in literature and how they define it. So they're able to, go through that systematic process, not just what we have done, but what others are also doing and sharing and our experiences. And I think so. The method that they used in that paper is quite good. The DEFA method is quite good. It's something that we can also do, in coming up with strategies that are really applicable or people in LMIC have you. So that's the way I'll go about it. I want to get learn from also our colleagues that are implementing this U1 grants. What have they used? Going to the literature, saying what people also have used, and using maybe the DEFI method to consolidate and also agree on those strategies.
I mean, thank you so much. One of the things is that in this cycle of the UO1 from the NCI Cancer Institute, they have 4 UO1s that are implementing in Nigeria. So you see, these are all different things, looking at cervical cancer, looking at anal cancer, looking at different self-testing for cervical cancer, looking at different ways. And I'm hoping that all of those 4 big projects happening in Nigeria, that's a chance. And most of them use ERIC strategy in selecting their strategy in the funding, but also as they implement, I'm looking to see if there will be new strategies that are proposed or that there is a refinement of the existing ERIC strategy that people like, I think about it because what we're doing, our method of engagement, when you talk about stakeholder engagement, the way we have done it at Nisa is quite really different because there is, I remember you put in a grant and say you sensitize a community. Somebody asked me in the review committee, Eche, what does that mean in Nigeria? Is that giving bribes? I said, no, that's not giving bribes. That's sensitizing a community. So again, being able to use the right words, being able to explain what you mean when you say we are going to sensitization, what does that really mean in the context of the LMIC? Because you hardly see that word in ERIC strategy, but if you listen to the implementers in Nigeria, you will see over and over there's a sensitization. What does that mean? Exactly mean? How can you measure that? Did you succeed in sensitizing them? So that's the kind of thing that I'm hoping that we'll see from the LMIC as we adopt these strategies, use them to select our strategies, implement those strategies, that we can at least come back with either suggestion for refinement or maybe describe a new strategy that can be added to the taxonomy. But thank you all so much. I don't know if there are other questions, but I am learning a lot. If not, I want to thank everyone for attending this. What we try to do is every day, we take 2 hours of your day and hope that you learn something from here. This is our 3rd day. Tomorrow, if you believe that equity is part of research and that you should have those in your place, you should come back and listen to our own Tonia, show our own experience, what I call little steps of learning that. But then you will have the expert, the Professor Scatoris from Monash University in Australia, and she will talk about equity and how they have looked at it as a process and not a lens like I have looked at it. So you can learn a lot tomorrow. And then on Friday, you will talk about group model building from Dr. Ballard and Dr. Arono as they present, one about how they designed the GMB and one talking about how we actually used it. So this is what we think about in NISA Research Week. And if you think there are topics, if you think there are people that we should bring together, said, I have used this process very well, and we can bring somebody who either developed it or who have been very instrumental in developing that, and bring you that have used that as a pair so that we can learn not in theory, but actually to say, this is how we use ERIC strategy to select our strategy for a winning grant that we are implementing. So it is not hypothetical, but it's real. So thank you so much, Dr. Powell, and thank you, Dr. Olakunde, for bringing us this together. We look forward. Hope you can join us tomorrow. Thank you so much.
Thank you all.
Bye, everyone.